and CEO. Take it away.
Thank you very much. I'm Adam Rogers. I'm the CEO of NervGen Pharma. Spinal cord injury leading to paralysis has long been considered irreversible. I've known this as a physician. Many of you know this, and there are no pharmacologic treatments for it. Today, what I'm going to do is walk you through our clinical data demonstrating evidence of durable functional improvement after just 12 weeks of daily NVG-291 that's administered as a subcutaneous injection in our Connect SCI study. This was a randomized, placebo-controlled, double-blind study in individuals, and this is important, they were 1 to 10 years out from post-cervical spinal cord injury. The ability to reform synaptic connections and create meaningful functional improvement is possible because NVG-291 is the first drug that's targeting really the core biology of the issue with regenerating neurons, and that's chondroitin sulfate proteoglycans. And this is what's preventing the central nervous system from repairing itself. This opportunity is enormous. There are roughly 150,000 individuals in the United States alone that would meet the criteria of chronic tetraplegia, which is motor incomplete spinal cord injury from C7 or higher, that would be eligible for NVG-291 therapy in our next clinical trial. Following an end of phase 2 meeting that NervGen had with FDA in Q1 2026, NervGen is aligned with FDA on a single registrational study that is to start in mid-2026. NVG-291 is a 35 amino acid peptide. It's delivered conveniently at home as a subcutaneous injection, either by the individual, a caregiver, or their family member. And we are showing preclinical efficacy not just in spinal cord injury itself, but also in neurotrauma such as traumatic brain injury, traumatic hearing loss, as well as other neurodegenerative diseases, MS and ALS, where there's an upregulation of CSPGs. As you can see on the screen, spinal cord injury is an enormous unmet need. There are no approved pharmacologic treatments. This is a community, the spinal cord injury community is a community that is waiting for breakthrough treatment. There is no standard of care in these individuals. In the U.S. alone, there's over 300,000 individuals with spinal cord injury. And as I noted in the previous slide, and I'm sure that I'll repeat this again many times, roughly 50% of those individuals have motor incomplete spinal cord injury from C7 or higher. And so this is a large number of populations prevalence that can be treated by this drug. These individuals from the neck down have impairment of sensory and motor function. Most notably, they have loss of hand function, which is important because that's what we will be testing in our phase 3 clinical trial. Currently, when individuals have a spinal cord injury, they are admitted to the hospital, typically through the emergency room. They're medically stabilized, surgically stabilized, usually undergo 1 or 2 spinal surgeries to stabilize the column. And then usually in the United States, maybe a little bit longer in Canada, they receive roughly 2 to 3 months of physical therapy. And after that, they're on their own devices. And so as I stated earlier, there is no standard of care for these individuals. It's an enormous economic burden to undergo a spinal cord injury. It carries one of the highest associated costs of any medical condition, up to $8.3 million in lifetime costs. That's both in lost wages as well as insurance costs for these individuals. To the U.S. healthcare system, it's a $58 billion hit. And for individuals, the greatest function that they can regain is hand function. In the commercial setting, we believe that the potential opportunity is immense. If with a very conservative market penetration of roughly 10% in our target population of 150,000 individuals with chronic tetraplegia, we believe there is a potential annual revenue opportunity of over $2 billion. The success of NVG-291 is really on its ability to target the core biology that inhibits the CNS from repairing itself, which is CSPGs or chondroitin sulfate proteoglycans. CSPGs are present in the normal state. They are present in the extracellular matrix. They are present during embryogenesis, and in adulthood, they cement into the perineuronal net, which is seen up on the upper right-hand side of your slide, staining green with a green fluorescent protein. When there is damage to the central nervous system, as one sees in trauma, astrocytes flood into this area, they become reactive, and they upregulate the production of CSPGs, which creates a molecular barrier around the site of injury. So in the acute state, these CSPGs do play an important part. The problem is, while beneficial during this time, this acute injury, the CSPGs are never removed. The body doesn't know how to remove them. And so you are left with this abnormal upregulation of CSPGs, which you see in the bottom right-hand side of the slide, staining green for CSPGs. So there's just this enormous upregulation. And the persistent CSPGs, that is what is blocking neurons and their ability to reform and reconnect. The primary receptor through which CSPGs exert their inhibitory effects is through PTP sigma. This was identified around 2009, and it is a receptor that is present on neuronal growth cones. The NVG-291, which is a 35 amino acid peptide, it is a mimetic of the wedge domain of PTP sigma, and it's capable of interfering with the inhibitory cascade of these CSPGs. This enables neurons to reform, resprout, and remyelinate. The right-hand side of the slide, the two upper images, there's an injury in the middle of the spinal cord that's there. There is no staining for serotonin or 5-HT. When we add NVG-291, what we see is the ability to resprout and regrow these neurons, and we are able to measure for the deposition of serotonin in the spinal cord downstream. The Petri dish is here. If you look down below on the left, there is a dashed line. The staining of green are neurons. Inside the dashed line are CSPGs, and what you'll see on the left is a Petri dish, and these neurons, they will start to grow towards the area of CSPG, and once they interact with the CSPG, you're going to see the neuron retract. Now, in the past, scientists used to think, okay, this dystrophic end ball, that's a dead neuron. It's actually not a dead neuron. That neuron is sitting there, really in a quiescent state, interacting with the CSPG. On the right-hand side, what we do is we add NVG-291 to that area of the dashed line. So there's CSPGs in the dashed line. We add NVG-291 to the dish. The neurons are stated green. And what you see is you start to see the neurons are able to grow through and across the CSPG gradient. And so on the time-lapse photograph that you see on the right side of the screen that's now running, you'll see the neurons start to grow towards the CSPGs, retract a little bit, and then grow through the area of the CSPGs. Now, how does this go? Now, how does this affect an animal? So Dr. Silver, who invented this drug at Case Western Reserve, and many other labs around the world tested this drug, NVG-291, it used to be called ISP, in the lab. And so this is a physical model of spinal cord injury. There was a thoracic spinal cord injury that was initiated on these animals. On the left, and I'm not starting the video on purpose right now, you can see how the hind leg and the tail are being dragged across the plank. On the slide on the right, and the image on the right, you can see the tail is lifted, the rump of the animal is lifted, and the legs are elevated as well. And I'm going to run through the video. So you can watch the animal on the left-hand side drag its hind legs and its tail across the beam. On the left-hand side is an animal that was treated with NVG-291, and you can see it walk across, much more improved leg function, ability to elevate its leg. This is the phase 1b/2a Connect SCI study that was performed at a single center site in Chicago. The early results were presented last June of 2025. It was powered for statistical significance. There were 20 individuals, 10 in the treatment arm, which is in the upper darker portion and then 10 in the placebo arm. They received daily subcutaneous injection in the abdomen of the drug for 12 weeks. The primary endpoint at this point was motor evoked potential, measuring an electrical impulse either from the area of the injury out to the hand or the area of the injury down to the lower extremity. We took the individuals off drug after 12 weeks, and then we retested them again specifically for hand function, both at 12 and 16 weeks. And I will show you the results of discontinuing them off drug. Now, why did we stop drug and measure them again? Because in the animal studies, whenever we discontinued drug and followed the animals for an additional 4 weeks, and the animals received drug for 8 weeks, we would see continued improved function, indicating that there was neural regeneration. So the totality of data generated gives us really some confidence that NVG-291 has the ability to become the first approved pharmacologic treatment for spinal cord injury. These are the MEP results that we're seeing, and we hit statistical significance in the upper extremity. When we look at when we look at the startle MEP, what we're doing is we're measuring the effect of the drug on the reticulospinal tract signaling. In these individuals, the corticospinal tract, which really drives fine hand motion, is primarily affected, and the reticulospinal tract is unaffected. So there's really a hyperactive reticulospinal tract. And what we're looking for here is actually a decrease in the startle motor evoked potential. And so we give these individuals a loud noise, 100 decibel noise, and it primarily is measuring the reticulospinal tract. And we see a statistically significant reduction in the startle MEP in both the upper and lower extremity, giving evidence of neural repair and in these individuals, and really a rebalancing of the cortical and reticulospinal tracts. Looking at functional improvements, and this is quantitative prehension. Quantitative prehension are 4 individual hand tests. They are each individually validated. This is an FDA-recognized endpoint that was cleared by the FDA for use in Onward's ARC-X. It measures very fine hand functions, 4 individual tests. Each of them can stand alone on their own, and there's really no compensatory movements or mechanism that an individual can do to compensate for this. And there is an established minimally important difference, or a minimally clinically important difference of +2. So anything above +2 in an individual that is taking the GRASP quantitative prehension test is important, because above a 2, those are functions on a day-to-day basis that are really vital to an individual. Combing your hair, brushing your teeth, being able to use a fork, opening up a bottle of water. So really above that level, a person can independently perform functions. So what did we see from a quantitative prehension standpoint in the individuals that were treated versus compared in our study? And remember, these are individuals that are 1 to 10 years out from a cervical spinal cord injury. We had a 3.7 point improvement in GRASP quantitative prehension, which is the summation of all 4 of those tests at 12 weeks, far exceeding the placebo at 0.4. But I think what's most important, the MID of +2. So we exceed the MID of +2 by 1.7 points at week 12. We stopped the medication at week 12. We measured their GRASP quantitative prehension again at week 16. And what we see is a 4.4 point improvement in GRASP quantitative prehension compared to a 1.2 point improvement in placebo, still exceeding the MID of 2.0. So, from a placebo standpoint, spinal cord injury is a very heterogeneous disease. These individuals consider themselves snowflakes, as each one of them is unique in and of itself based on the mechanism of action and the injury that goes on. Regardless of the injury level and regardless of the mechanism of action of the injury, after 12 months, these individuals have no spontaneous improvement in function. We also did blinded exit interviews that was conducted up to 1 year out from when these individuals left the study. On average, it was done 259 days out. And really, we wanted to understand the whole body effect and really contextualize the improvements that these individuals are seeing, more than just a number on a chart. And so what we saw from a PGIC, or patient global impression of change, 75% of these individuals were very much or much improved compared to 33% on placebo. There 67% showed improved bladder function. And by that, what do we mean? Less catheterization, less leakage, ability to know when they needed to void, confidence that they weren't going to have a leaking episode, that they could drive in a car or sleep in a bed and know that they weren't going to have an accident. And really, one of the most impressive things is a reduction in muscle spasticity in 56% of the individuals. And going back to the startle MEP that we saw, showing the reduction in hyperactive reticulospinal tract, that really opens up and relieves the involuntary muscle response that these individuals have. So relaxing their muscles, improving their bladder function, and really opening up their hand function. So that startle MEP is really the key to unlocking most of, if not all of, the functional improvements that we're seeing. In their own words, what did this do? I can open up a bottle of water. I can feed myself, brush my hair, comb my teeth. That is the difference. When you exceed that MID of 2, that is the difference between someone that needs at-home care, that they can now live on their own. They can transfer themselves to a chair. They don't need a family member with them all the time. So the individuals that received the drug, it was really a tremendous improvement in their confidence, in their dignity, and in their ability to live on a day-to-day basis and function. We are also continuing to look at really from a whole body standpoint, walking in these individuals. We perform a 10-meter walk test in all individuals, but we are currently evaluating, we're doing a video analysis of walking, looking at smoothness of their joint function compared to compensatory movement. But in general, this is one of 2 individuals that was unable to complete the 10-meter walk test when he entered the study. Same individual, he just shaved his hair and shaved his beard, but same pants, and you'll see him. What I really think is very interesting in this individual, he is having a difficult time walking. You'll see there's an individual, a physical therapist behind him, who's really locking and unlocking his legs. He's having to really slide his legs across the floor, and he was unable to finish the 10-meter walk test. After 12 weeks of subcutaneous NVG-291, I think what's most important to look at is his thigh function and his quadricep function. He's really starting to lifting his legs. Obviously, there's still a woman behind him for safety, but he really doesn't need her. He's lifting his legs. He's straightening his legs. He's able to bend his knee, and he's no longer shuffling his feet across. From a safety standpoint, NVG-291 administered daily for 12 weeks was very well tolerated. We had no SAEs. We did have injection site reactions, which were sporadic, did not bother the individual at all. We cannot determine when they're going to get it. We pre-treat these individuals with cetirizine. So really very well tolerated. All individuals that started the study finished the study, and 99.8% of all injections were given to all the individuals. So clearly, there was no one dropped out and no one discontinued treatment whatsoever. The Restore registrational study, this is our phase 3 single registrational study that we plan to start enrolling mid-2026. There are 150 individuals. Again, this is very, very similar to what you saw in the Connect SCI study. The same inclusion-exclusion criteria. It is powered. The difference is it's powered for a primary endpoint of GRASS quantitative prehension at 12 weeks. We are powered to detect a GRASS quantitative prehension difference of 2.5 points. And again, it's 12 weeks of daily subcutaneous injection, and we will follow the individuals again off drug for an additional 4 weeks out to 16 weeks, where we will retest the quantitative prehension. With our meeting with FDA, we are aligned on the primary endpoint. The key secondary endpoints are hierarchically aligned, and as you can see, the FDA and ourselves were very much interested on how does the individual feel and respond to this drug. The FDA was very, very intent on understanding from a global aspect, how does this drug impact someone's life on a day-to-day basis. So as you can see, patient global impression of change followed by clinician global impression of change are really the two key secondary endpoints. We will also do a blinded qualitative exit interview. It's a 75-minute interview within 4 weeks of the individual's discontinuing the study, and we'll also do kinematic data analysis as well. From a near-term catalyst, we have completed some significant milestones at the company. We uplisted to NASDAQ in early January 2026. We had a end of phase 2 meeting with FDA in Q1. We plan to announce additional indications in mid-2026, focusing on neurotrauma and neurodegenerative disorders where there is an upregulation of CSPGs, given our drug and the biology of CSPGs. We will initiate a phase 3 clinical trial this summer, as I discussed earlier. So I want to thank all of you for your time today. As a physician and the CEO of this company, I am very confident that based on what we've seen in the Connect SCI study, that this will be the first FDA drug approved for neuroregeneration. And I thank you all for your time.
Thank you so much. Any questions? Just raise your hand. Thanks.
Hi, amazing presentation. I'm an incoming grad student at the University of Toronto, just for context. But I was wondering if there was any difference in the change from baseline with the different patients who, let's say, were 1 year out from their injury versus 10 years out. Was there a difference in improvement there?
We didn't really see much difference. One of the individuals that received drug and had a very positive response was 9 years out from her injury. So we haven't. Time from injury doesn't really seem to be an issue. I think when I got into this company, I think the mentality is when you have a significant, very severe injury like spinal cord injury, the first inclination is you've got to tackle this immediately. And that was when I first got involved. What we find and what Dr. Silver found in the lab is that with time, there's more sprouting of neurons in the spinal cord in the area of injury. So I think what we're seeing is the ability of NVG-291 to disinhibit the CSPGs and over time allow those neurons that are ready to resprout and ready to reconnect. You're giving them the opportunity to do that with the drug. The 10 years is an arbitrary number. Really, from a standpoint, 1 year, from the 1 year point on, these individuals can spontaneously improve from 6 to 9 and up to 12 months. So that's why we start at 1 year. We want to limit the ability of spontaneous improvement to occur.
You talk about, earlier in the conversation, talked about TBI, traumatic loss, and ALS. I'm assuming that these guys, or the conditions indicate CSPGs. Can you talk about just the opportunity in TBI alone and how would it compare to the 150,000 that are in the kind of spinal
I don't have the numbers off the top of my head for TBI, but there are no treatments available for traumatic brain injury. There has been, I can tell you, we've had a number of contracts with the U.S. Department of Defense. They have spent $6 billion on treatments to try to tackle traumatic brain injury, and all for the most part in the anti-inflammatory space. So there is an enormous potential there. And we are finishing up with the preclinical study, working with Walter Reed Rare, on TBI, and that information has not been made public yet.
For sake of time, I'm just going to make sure we get one other person.
That phase 3 registration trial, can you just bring that slide up again? Was that compared to placebo, or was it?
Yes, it's 1-to-1. It's double-blind, placebo-controlled trial.
So the primary objective is a 2.5 points improvement from baseline to endpoint?
It's for a 2.5 point difference. That's what we powered it for.
Now, what about beyond 12 weeks? How durable is the response, and is there any thoughts of doing a long-term?
Down the road, yes. Right now, there is such an enormous unmet need, and individuals with spinal cord injury have no pharmacologic treatments available to them, that we elected to finish this at 12 weeks because we can power the study and show statistical significance at that point.
All right, just for sake of time, I have to wrap it up there, but I encourage you to ask Dr. Rogers your questions afterwards.
Thank you.
Thank you very much.